Hi everyone, welcome to week 3, right? Chapter 14. We're skipping ahead this week to look at the different psychological disorders in chapter 14. Next week we'll look at chapter 15, the treatments and therapies available for the disorders. And this is to give you the opportunity to choose early on in the semester a topic for your PowerPoint presentations, which aren't due till the end of the semester. But we like to cover these at the beginning just to kind of give you a flavor for what you might have expected psychology to be about, which is about, a lot of it is about these disorders. We also have a class at GBC every spring based solely on the disorders, Psych 241. And most of them are sad but interesting. So this will be a bit longer of a lecture today. We'll introduce it with the first 10 or 11 slides, just kind of introducing the topic, and then if you want to cut off after that, you can. I'll let you know, because then I'll be going into detail about each one of the disorders, and that takes a little bit of time this week. So let's begin. All right, our chapter outcome for this week is number 14, given descriptions of abnormal behavior. Students will identify and describe the main types of psychological disorders. So we're going to start out by trying to define what is abnormal behavior, so we have a handle on that, and then we'll look at the different types. We'll also bring in a little bit the 7 perspectives or the biopsychosocial approach to understand the causes of these disorders. All right, so in this chapter we're looking at disorders, people who are mentally ill. And the question becomes, when do we cross that line? Excuse me, when do we cross the line from being normal to being ill, to being mentally ill? Just like when do we cross the line from being healthy to being sick? So this is a question that psychologists have grappled with over the years, many, many years. And the reigning perspective or structure or model for this is the 3 Ds. Or 4 Ds, as you'll see here. So let's look briefly at each one of these. They're very important, and we will be referring back to them throughout the semester, or throughout the chapter. So number 1, deviance, behavior that deviates from the norm. So for something to be abnormal, it needs to be deviant, whether that means it's improper for the situation, it's improper for the culture, it's improper for that society in some way. So again, that can be interpreted differently, and one behavior that's appropriate in one situation can be the same behavior in a different situation and not be appropriate. So this one is tricky. You have to be very careful about saying that a behavior is deviant, because we have to know all the factors involved and the context involved. The second D is distress. The book labels it personal distress, but most books you'll see it as just distress. And this is the distress for the person involved. So the behavior that they're doing, the abnormal behavior, causes them emotional or physical distress. So whatever the disorder is or whatever behaviors it's causing, the person doesn't like it, generally speaking. So for most disorders, people are aware they have a disorder. They don't like feeling depressed. They don't like feeling anxious. They don't like feeling separated from reality, and it's very distressful for them. They want to be rid of it. They want to be free of this behavior. That's not always the case. In some specific disorders, sometimes in schizophrenia, sometimes in bipolar and a manic phase, there is no distress. The people like that or accept that as who they are, and it's not distressful for them. In fact, sometimes it's helpful to them. That's how they perceive it. So this one, again, we have to say sometimes that number 2 isn't always there, number 2 being distress, but most of the time it is. For most of the disorders, people don't like what's happening to them. Number 3 is a really important one, and I would say probably the most important one personally for me. Dysfunction, and interferes with their ability to work and or disrupts relationships. So sometimes you'll see people who have some behaviors, some disorders, but they're still able to maintain a job. they're still able to be a parent. They're still able to maintain an intimate relationship with a significant other. It doesn't mean that they're not mentally ill. It just means that it's maybe manageable. People who have mental illness and it's not being treated, generally that abnormality that they're experiencing, the behaviors that they're doing, interferes with them being able to maintain a normal lifestyle. So, and that's often when you'll see people coming in for help, is that they've lost their job, they can't take care of themselves, is another one that comes into this criteria. So if you can't take care of yourself or maintain relationships or take care of others, then there's dysfunction there that needs to be dealt with. Number 4, danger, you'll see is in parentheses, the risk of harming self or others. Some psychologists, psychiatrists will not include this. They'll only have 3 Ds, not 4, because the risk of including danger as a criteria for abnormality is that it implies that people who are mentally ill are dangerous. And in fact, if you look at the statistics, people who harm others are no more likely to be mentally ill than people who aren't mentally ill. The statistic is the same. So risk of harming others is a little bit, actually quite misleading, because it's also reinforced in the media and the movies that, you know, if you're mentally ill, you're going to go out and whack somebody. The risk of harming yourself is higher if you are mentally ill, especially specific mental illnesses. But again, it can be a bit misleading to label people who are mentally ill as being dangerous. So I always put that in parentheses because I don't really like that one. I think it's very stereotypical and misleading. So look at these 3 or 4 Ds and keep those in mind as we look at some videos in our discussions, as we look at examples of people with these disorders, and as you do your own research for your PowerPoint presentations about the disorders, keeping in mind these criteria. Okay, so those 3 or 4 Ds are pretty open. They're pretty wide in terms of their ability to say whether or not somebody has a disorder. So clinicians, psychiatrists, psychologists have come up with a manual, the Diagnostic and Statistical Manual, DSM, for TR. So we've gone through many phases of this DSM. There was a DSM 1, 2, a 3. I think there was a 3R, and then a 4, and then a 4R. So over the years, the understanding of abnormal behavior has changed and improved, but it's also, if you'll notice, the books have gotten bigger. So one year I had a student bring in, she had all the copies since the beginning, since DSM-1, and the DSM-1 was very small. It was just like a little pamphlet almost, and you stacked them up next to the other DSMs that just get bigger and bigger every year. So I'm not sure what that says. Are we getting sicker? Are we getting better at diagnosing, or are we just making more people, labeling more people as mentally ill? Let's look at the DSM. It's a tool used by mental health professionals to diagnose, not to treat. It doesn't tell you how to treat, just tells you how to diagnose. That's all it is. Created by committees and lists criteria that a person must meet in order to receive that diagnosis. So it's very specific. You have to have 7 out of 10 of these criteria. You can't meet any other criteria for any other disorders. You can't be involved in alcohol or substance abuse. You have to have, you know, three symptoms in this category and 4 in this category. So very specific, and there's good and bad with that. It's somewhat controversial in some ways, and as I said, it keeps growing with every edition. But this latest DSM that just came out a year or 2 ago was very controversial. A lot of people didn't like it. People in the field thought that it was becoming too specific and was categorizing several of the disorders wrong. So how do you categorize disorders? How do you slice them up into little boxes? Well, it helps you, and as we'll see, there's pros and cons to doing that. It helps in some ways, but in other ways, you know, it begs the question, can we really cut mental disorders up into little chunks? Or is mental abnormality, behavioral abnormality, is it all just one big spectrum of the same thing? And so there's some controversy about whether or not this DSM is a good thing. I've put these next two slides in here. I think they fit better here. In the book, you'll find this information at the very end of the chapter, the benefits and costs of labeling people. When I was in my training as a counselor, we were taught very specifically, you do not label people. You do not call a person an alcoholic. You do not call them a schizophrenic. And obviously, we'll talk about that in the discussion, there's some implications there of calling someone by that name, because then that's who they are. They are schizophrenia. They are alcoholism. And that's not true. They're people who have an illness. And so we were very careful not to be heard ever saying schizophrenic, alcoholic. It's kind of like saying a diabetic, that's all they are, is their diabetes. So we want to be very careful about how we label people and if we even label them at all. But there are benefits. If you can give a label to someone, they often can get the treatment, not only because that's how therapists, psychiatrists are trained to treat people based on their label, but it also allows people to communicate, other professionals where you have a multi-approach, helps with conducting research, helps with reporting health statistics. It also helps you get money to be insured for treatment. So if you don't have a number, if your diagnosis does not give you the right number, then the insurance company won't treat you for your number. So unfortunately, in our world that we live in order to get help, you often need the label. And finally, the costs. We've talked about some of these. If you label someone in a certain way, then there's that stigma, that negative public attitude in society and at work and in your personal lives. And a lot of people are afraid to be labeled, to be treated, because then they're labeled as a depressive person, you know, person with depression or a person with OCD. It can affect their self-esteem, can lead to greater likelihood of depression. And then, as we talked about, the person becomes the label, and it can become a self-fulfilling prophecy. So, for example, if a child is labeled as ADHD, even if they're not ADHD, then kids are smart enough today, they know what that means, and they know that they can get certain benefits from that label. So they can actually start acting in ways to fulfill that prophecy, and not even in a conscious way, but often in a very unconscious way. As we'll see later, the self-fulfilling prophecy is a very real phenomenon, and people will often rise to the level or lower to the level of your expectations at an unconscious level based on that expectation. So pros and cons to the labeling. One final factor as we look at how we're defining abnormality, how we're labeling people, is the culture. And if you've studied anthropology, I'm sure Professor Walsh hit on this. Culture-bound syndromes are very interesting because these are disorders that are found only in specific cultures. For example, the disorder called ZAR. In Ethiopia, they believe that spirit possession can leave a person unable to speak or with uncontrollable body movements. So we might call that a seizure. They call it ZAR, and that's how they explain it. Some of these culture-bound syndromes are seem to be different names for similar syndromes. Some of them are completely different, ones that we seem very strange to us, and that lead to behaviors of disorders that we don't have here. So it kind of begs the question, what is the cause? Why does abnormality occur? Is it biological, or is the cultural influence stronger than we thought? So speaking of causes, let's look at the biopsychosocial view, and you'll see the 7 perspectives involved here. And this applies to all disorders. However, as you go through, and you'll need to do this with your disorder, You'll need to look at each of the 7 perspectives, which is basically the biopsychosocial perspective or view, and apply it. And you'll see that some parts of it apply better and some don't. So for example, we're going to look at schizophrenia as an example in a moment here, but let's look at depression as an example. Depression and the symptoms of depression can be caused from the biological view by faulty genes. So it can be in your genes. It could be something that you inherited biochemically that you don't have a lot of control over. Chemical imbalances in the brain. So those neurotransmitters and other hormones are not functioning properly, and therefore that's what's causing the depression. Or abnormalities in the structures of the brain. So some structures being too small, some being too large, some not connecting like they should, and maybe that's causing the depression. So there's a lot of evidence for some of the disorders for the biological view, like schizophrenia is a big one that we're discovering. There's a lot of biology involved there. Some of them not so much. For example, personality disorders. We can't seem to find a lot of biology there for that one. Psychological view, where we've got unresolved conflicts, so that's the psychodynamic. That something happened in your childhood that was unresolved and that's causing you to be depressed. Cognitive factors, it's your thinking. Your thoughts are maladaptive, are abnormal, and that's causing the depression. Blocked growth, that's the humanistic. So something is causing you to not reach your full potential. You're not feeling good about yourself. There's something affecting your feelings of worth, and that's causing the depression. And then learned behavior. You're being reinforced somehow from your environment. You're being punished or rewarded for behavior that leads to depression. And then we have the sociocultural view, which of course is the wider look at the causes. Disorders explained in terms of larger societal factors that apply to groups of people. And that's really the key with this one. Looking at the groups of people, male versus female, Americans versus British, wealthy versus poor. Include stress created by marriage, family, race, class, and culture, or any other groupings you can think of. And we're going to look just a moment here at how that stress works, but that something happens where there's a stressor in your environment. There's a stressor in your marriage, in your family, in your ethnic heritage or your race, and that triggers something that causes disorder or abnormality. So in the case of depression, of course, we're seeing there's maybe stress at work, and the stress at work is seen as uncontrollable. It's something you can't control, you're stuck with, and so the stress is constant, and that is what leads to the depression. So you'll see the stress vulnerability model. This is another explanation for the causes of disorder, but you'll see that it involves biological, environmental, which is the kind of the social, and then the psychological. And so we have these risk factors, these things that sort of are pre-programming us, whether it's genetics, our brain chemistry, or structural abnormalities. We talked about those, but there could be other factors. We're in a situation where we're being abused, where we're being discriminated against, where we don't have money, food, home, or maybe we are somehow we were born with, or we were led to have distortions in thinking, where our thinking process is just not good, or we never learned how to cope with things. And so if we have these risk factors, if we have any one or more of any of these things that is in our life, and then there's stress. Something comes along in our life, and it's, remember, stress is some kind of pressure from the environment on the organism that causes it to have to react and change. So if we have that stress, that pressure from the environment, and we have these risk factors, then that's what can lead to the psychopathology or the disorder or the abnormality. And that's why some people can experience all this stress coming in. But if they don't have these risk factors, then the stress isn't going to lead to the pathology. It's just going to be dealt with in some way and not lead to disorder or dysfunction. And that explains why two people can experience the same stress, and one develops disorder, one doesn't. And this is when they've looked at with twins, identical twins who have schizophrenia. So both have the same genetics, but end up one with schizophrenia and one doesn't end up with schizophrenia. And they think it's something to do with stress at critical points in the development that led to changes that either, didn't, the one twin did experience the stress, the one twin didn't. And so the one that did ended up with the schizophrenia. So it's a good model, but then again, many of us look at these risk factors and think, well, probably I've got at least one of those risk factors in my life. So aren't we all vulnerable in some way? All right, so we've looked at all the factors that define abnormality and cause disorder. Next up, we're going to look at the disorders. So if you don't want to go through this whole next part, you've kind of hit most of the fundamentals here. You can check out at this point if you'd like to. If you'd like to stick with me, I'm going to try and go through them as quickly as I can. Like I said, we have a whole class on this, so it's kind of like taking a whole class. Actually, all of these chapters in Psych 101 are like taking a whole class and putting it into 1 week, which can be tough to do. So hopefully this lecture will help. All right, we start out by looking at the childhood disorders, and we're not going to look at each of these. There's a few discussed in the book, but autism, of course, is the big one. And we call it now autism spectrum disorders because it involves a wide array of behaviors and disorders, including what used to be known as Asperger's. So there's impairments in social interaction, communication, ability to connect basically with others. And of course, usually diagnosed very early. You don't have autism diagnosed later in life, unless it was never properly diagnosed and it was lower on that spectrum. So the good news with autism is there's so much more known about it than there was 20 years ago. There are tons of different ways of treating it beyond the original behavioral interventions, but they still don't really know what causes it, and so they aren't able yet to prevent it. It's still escalating, and it's a very sad disorder. If you've ever watched a child go from being normal, quote unquote, interactive, talking, to being closed off in their own world, and knowing that there's no treatment for that they probably will never come out of that completely. It's very sad, very depressing. All right, moving into the big one, schizophrenia. Disorder characterized by delusions, hallucinations, and disorganized thinking and speech. Schizo, of course, means split or break. So thoughts and emotions are so impaired that the person splits or breaks not from themselves, but from external reality. So there's a big stereotype or a big miscommunication out there that schizophrenia means split personality, and the two are very different disorders. They're in completely different categories of disorders. Split personality is a split from yourself, so where the personality splits into different groups, and that it's has a different name today too. We'll talk about that in a minute. Schizophrenia is a split from reality. So the person is split from what's really going on in the world. Falls within the larger category of psychotic disorders, and there's several different psychotic disorders, but this is the big one. There are 5 types discussed in this chapter. We're not going to look at each one, but I just want to point out that, again, we tend to associate schizophrenia with extreme weirdness, kind of scariness, maybe dangerousness. There are many people with schizophrenia who are able to actually treat this disorder, who are able to actually hold jobs, have relationships, but often long-term that breaks down is the problem with schizophrenia. And if you've ever talked to someone with schizophrenia, it's actually a very heartbreaking disease because remember, many people with disorders were quote-unquote normal. They were just like everybody else, leading a normal life, going to school, having relationships, getting a job, and then often in early adulthood, this disorder will come on, and it's probably, in many ways, the most debilitating of all the disorders, because if you don't have a handle on reality, you don't have a life. And so I've talked to people with schizophrenia who just, it's very sad and depressing for them because they know that they used to be fine. And now this disease has taken hold of their brain and they can no longer live a normal life. So with all these disorders, one thing I want you to remember is that these are just people. These are not crazy people separate from the rest of us. These are us. Chances are the 120 people in this class right now listening to this lecture, several of you are dealing with mental illness yourselves. And so it's kind of like when you get cancer or when you get diabetes. It's something that happens to you and you have to deal with it. And it's not something often that you have caused. It's something that's gone wrong. And dealing with it is your task in life. Okay, one thing to point out with schizophrenia that's often confusing, the positive and negative symptoms, we think of those as good and bad, good symptoms and bad symptoms. No, positive means addition and negative means absence or taking away. And this will be the same when we look at learning. So keep this in mind that in psychology, positive is adding, negative is taking away. Adding unusual thoughts and behaviors, things that normal, quote-unquote, people don't have. All the stuff we tend to associate with schizophrenia, the extra weird stuff, that's the positive symptoms. Negative is when we take away stuff that should be there. So normal emotions, normal interaction with people, normal ability to get up and brush your teeth in the morning, normal ability to just talk and form a sentence. So missing those symptoms is the negative symptoms of schizophrenia. And if you look at the 5 different types talked about in the chapter, some of them are heavier on the positive and some of them are heavier on the negative. All right, this is when we're going to go into the causes of schizophrenia, and you'll see that the biological is heavier here. But again, we should be able to apply the whole biopsychosocial social approach to all of these disorders. Biological genetics is huge. Family, twin, and adoption studies suggest a genetic component, so even twins raised apart often will both develop schizophrenia. And so, unfortunately, if you had parents, and I think the book goes into, you know, your susceptibility based on if it was your parents, if it was an aunt, if it was a sibling. The highest, of course, is a twin that has it. You're most likely to get it in that situation. Then we have the neurochemistry, the neurotransmitters not working properly. And then we have structural abnormalities of the brain. This is a big one. If you look at the brain of someone with schizophrenia, it looks very different than someone without. And there's bigger spaces, those are ventricles in the brain. And the frontal cortex, which as you know from last week, is the thing that helps us think critically, plan, and analyze, and sort of the smart part of our brain where we figure stuff out and make decisions. That part doesn't work so well in people with schizophrenia. And as we'll look at with several of these disorders, schizophrenia and depression especially, they know that the brain of people with these disorders looks different. But the question is, especially in the case of depression, does the brain look different because the depression made it that way, or was the brain different to start with and that led to the depression? They still don't know the answer to that. They just know they look different, but they don't know if the chicken came first or the egg. So we're learning a lot, but the more we learn, the more we realize we don't know. The sociocultural and the psychological, it's kind of both here, used to be unhealthy family interactions. So this used to be Freud thinking, something went wrong, and it was usually the mom. The mom was to blame, that she didn't raise the kid right, and so that's what caused this craziness. That we know is really not true. We don't blame moms anymore, luckily, for that. Although there can be some of that. If there was extreme abuse or extreme weirdness, then we can't discount that fact. But normal everyday family, dynamics is not to cause. Psychological variables, personality variables such as neuroticism, that's less, should be in a separate one, not under sociocultural, but so certain people with a certain psychological makeup tend to be more prone to schizophrenia. And then we have those environmental stressors where if there's lots of stress, negative life events, and environments, again, if you have that predisposition because of maybe a really messed up childhood, but more likely because of genetics, then if the stressor comes along in the environment, then that can be something that causes schizophrenia. Another one that's not mentioned in this book, I don't think, but was mentioned in our old book, is viruses, in utero viruses. Don't you love me trying to write on here? Virus. During a certain trimester, and I don't want to scare anybody because this isn't doctrine yet, but during, I think it's the second trimester, there's certain viruses that they have actually connected to schizophrenia later in life. So if the mother had a certain type of flu virus in a certain trimester, there seems to be some connection there. So that should be back in the biological, but of course, again, as we look at these, we really are struck by how little we do know. Because if we knew what caused most of these, then maybe we could fix them better. But as you'll see, although we can intervene and make some of the symptoms better of many of these, including schizophrenia, oftentimes it's a lifelong thing, and you're never fully free of it, just like you're always an alcoholic, bad to say, but we said it anyway. Then once you have schizophrenia, you kind of always have it, although symptoms can often really recede and get better the older you get as you enter old age. Okay, moving on to mood disorders. We have basically two big groups of mood disorders. The bipolar, which we used to call manic depression, we don't anymore, we call it bipolar, where we shift between depression and mania. Mania, a person may feel elated, agitated, and energetic, or have delusional thoughts. And sometimes we don't realize that agitation can often include anger. I've seen people who have mania, and the mania comes out not as this sort of, wonderful feeling of happiness, and I'm so creative, and I can jump off buildings, and I can, I can travel the world, and it often comes out as anger, sort of this unrelenting anger that can be directed towards people. It can also come out as promiscuity, so thinking that you can have lots of sexual partners with no repercussions of that. So the mania can look very different depending on the person. Another type of bipolar is called cyclothymia, which is a milder, more chronic form of bipolar. They're not as severe symptoms, but they tend to last longer. So there's still the ups and downs, but it's more over a longer period of time, whereas as opposed to the bipolar, where you'll see extremes, but the period of time for the cycle is shorter. So here's an example of that, where we have the bipolar is really this big one going up and down, and then you have the cyclothymia, and there's specific criteria you have to meet for that. So this is more than those of us who don't have these disorders. We're kind of more like, maybe in here. We're closer to this line, okay? Cyclothymia is enough that it's not normal, and obviously bipolar is the huge one. But the cyclothymia tends to be longer lasting. So in some ways that's more difficult than the bipolar. So we looked at the ones that are way up and down. Now we have the ones where people are just one or the other. Unipolar depression, feelings of sadness, hopelessness, worthlessness that are lasting and impair everyday functioning, can affect your cognitive, affective, which is your feelings, and behavioral symptoms. And usually we know this as major depressive disorder, characterized by one or more episodes, which can last for at least 2 weeks or need to last for at least 2 weeks. Depressed mood and a loss of interest or pleasure in normal activities. So what used to be, for years, a normal thing the person would do to help themselves feel better, they either can't do it or they do it and it doesn't help. It's a pretty high number, 6 to 7% of the population, and twice as many females. And one thing to remember with this depression, just like all the other disorders, this is a disorder. This is an illness. This isn't something that can be fixed, usually by pulling up your bootstraps, by changing your perspective, by having a better attitude. People who have major depressive disorder would love to be able to pull up the bootstraps. They would love to be able to just think happy thoughts and feel better, but they can't. It's a very real disorder. It's a very trapped feeling that these people have. They're trapped in this constant gloom and cloud, and there's a feeling of no escape. So just keep in mind that being depressed is very different than having a major depressive disorder. And here we see some of the symptoms of depression, just showing how it affects our thoughts. Can be suicidal. Concentration and memory is a big one. It affects our feelings, that disconnectedness. Guilt is a big one that people with depression feel. And then behaviors, you will see it outwardly. They'll change their sleeping, their eating habits. They'll withdraw. So this is kind of a good look at how it affects all parts of us, and it's not just thoughts or feelings, it's behaviors as well. And then just like we had the cyclothymia with the manic depression or the bipolar, we have the dysthymia, which is the milder but more chronic form of unipolar depression. 3 symptoms of depression that have lasted for at least 2 years. So this is where you're staying below that, you've got the normal line, and then you're just depression, major depression, maybe you're down here. Dysthymia, you're just kind of down here most of the time, never getting back up to normal. All right, looking at the next and biggest grouping of disorders, you'll see 29% lifetime prevalence rate. Sometime in their lifetime, 29% of us will get some form of anxiety disorder. So pervasive and severe feelings of anxiousness, nervousness, or fear that happen during inappropriate times or situations. So we all get nervous, we all get anxious, we all have fear, but these feelings are above and beyond normal, and they happen in places where they really kind of shouldn't happen, or they should quickly go away for the normal person. Again, twice as likely among females, more common than any other category of mental illness. Let's look at a few types here. The GAD, generalized anxiety. You just kind of always feel worried, dreading something, stressed. Your thoughts are running a mile a minute. You're nervous. And they don't know, again, what causes it. It may be very biological due to the CNS. It may be an overactive fight or flight system that's happening. Your sympathetic and parasympathetic is not working properly. But it's sort of this, if we're here, normal is here, then it's always above. You're always sort of in this elevated state of anxiety. And again, this isn't just, something that people can control. It's a very real disorder. And there's a feeling of strong dysfunction and strong distress with this one. You cannot control that feeling of worry and nervousness. It's always there. Another type of anxiety disorder is a panic attack or an anxiety attack. If you've ever had one of these, it's very scary. It makes you feel like something bad is going to happen. You're going to die. The world's going to end. You're going to have a heart attack. It's always something extreme and irrational, but very real. And so we have these symptoms, nausea, sweating, chest pain, rapid breathing, all of these physical things start happening, where it's kind of like the flight preparation. You're in this extreme state of needing to get out of there, but there's no cause for it. It's not like you've come across a bear or there's an earthquake happening or something. There's zero cause in the environment that is precipitating this. And then if we look at what's happening in the brain, you've got your thalamus causing sensory overload. So there's all of the senses are heightened and it's too much, and you can't focus, you can't think, especially because this frontal brain is not working as well because this thalamus is overreacting. So just know that people that have these, they can't control them, although they are fairly controllable with the right medication. But that they're very real and very scary, even though there's no actual event in the environment causing it. And then we have phobias. We're not going to go into all the different ones, but again, they are irrational and they are anxiety producing. Maybe focused on harmless objects or specific situations. So fear of open spaces, fear of closed spaces. Fear is excessive and inappropriate in relation to the amount of danger, and it interferes with your daily living. So if you're so scared of open spaces that you literally can never leave your house, you can see how that would be dysfunctional. And that happens to people. That's the level of anxiety we're talking about with phobias. People often have arachnophobia. They're scared of spiders. Actual arachnophobia is takes that fear that we all have to the next level. So for example, you are fumigating your house every day. You refuse to go to work because somebody spotted a spider there, and so you quit your job. So irrational is kind of the key word with phobias. Okay, OCD, this is a term we've all heard, and I want to point out that there's the OCD talked about kind of in the general public. There's the obsessive compulsive disorder, and then there's also an obsessive compulsive personality disorder. So there's two different types of diagnosable OCD, and then there's the OCD that we hear about in the world today. Oh, she's so OCD, meaning she's kind of overly organized. She likes things to be just perfect in a certain way. That's different than someone who has the actual disorder. And as you'll see, we're going to watch a video about this in our discussions. It's very good because it helps you see the repetitive behaviors, the intrusive thoughts, and how dysfunctional that is for people. The obsession, of course, is the thoughts that people have that something's wrong, that something's dirty, that something's out of place, and the thought will not go away until you do something, and that's the compulsion. So that's the behavior where once you do the behavior, that horrible nagging obsession thought that you literally can't do anything else because that's all you can think about, it goes away once you complete that behavior. The problem is you can see how that can lead to you having to do the behavior over and over and over until you pretty much, that's all you're doing literally all day is repetitive behaviors. So a true OCD person is very dysfunctional and very distressed. All right, moving into the dissociative disorders, where we have the split from, there's a separation within the self, and you're separated from your memory, from different states of consciousness, from perception, even from your own identity. Depersonalization disorder, this is a little bit more difficult to understand because it's not very common. I've never seen this disorder myself. Persistent or recurrent feelings of being detached from your own experiences, having out-of-body experiences that aren't chemically induced, that have no other explanation, but that are meet the 3 Ds. They're distressing, they're dysfunctional, and not normal. You'll see with most of these dissociative disorders, people are dissociating from themselves in some way to deal with some kind of trauma. So there was child abuse, there was a traumatic event, and the person, the coping mechanisms don't work. So they split from themselves in some way to detach from those feelings of trauma that they experienced. And depersonalization is one way of doing this. Okay, here's the split personality, which is actually called dissociative identity disorder. It's not schizophrenia, it's very different. A person's consciousness becomes divided into two or more. As you may have heard, that more can be a lot, more distinct personalities. Each personality may have its own memories, characteristics, physiology, personal history, and again, but not always, often begins in childhood and is a coping mechanism. So the person splits from themselves to deal with, often it's more than just one event, it's a continued trauma to the child or the person. And so in order to deal with that and keep one part of themselves intact, they split from it and they create these different personalities. And so if you've seen some of the movies, United States of Terror, it kind of actually is like that. Although there is some controversy, and some of you will get into this in your PowerPoints, that this disorder even exists. Some people, some psychiatrists feel that this is not a real disorder, that there just isn't enough evidence for this being an unconscious process. They feel that this is one that the person consciously uses to deal with problems that they're having. I tend to disagree with that. I think there is enough evidence and history of this disorder to merit its validity. Sorry, moving into somatoform, we're almost at the end, which has to do with physical illness. So the first one is the hypochondriasis. You've probably heard, again, the term hypochondriac, which we don't want to use, right? That's a label. Intense fear of having a serious illness despite reassurance that no illness exists. So the key with this one is the person is always worried that there's something wrong with them, and there is nothing wrong with them. So physically, there's nothing wrong with them. They're just worried that something is going to be wrong with them, or that if a normal symptom comes up, that it means that they have cancer, or they have a tumor, or they have something horribly wrong with them. So it's irrational, it's excessive, it's dysfunctional, it's distressful, and it's real. The problem is that it's often overdiagnosed. In the medical literature, you'll see that people can be diagnosed with hypochondriasis when they actually do have something wrong with them. So this is a dangerous diagnosis in some ways. The doctor has to be very sure that there actually is no illness, or that there is a history here of the person jumping around to different doctors, wanting to get that, confirmation that there is something wrong with them, when they've seen literally 10 different doctors and all have said, no, there's nothing wrong. And here's just again to show you that this, when it is real, it's real. And it affects thoughts, behaviors, perceptions, and emotions. And you'll see worry. You'll see that others don't take them seriously. You'll see the different behaviors that people have even back when they were a child. So I like these little charts, figures, because they show us how all of these disorders usually affect more than just thoughts or more than just feelings. Another somatoform disorder that's kind of the opposite of hypochondriasis is conversion disorder. This is when there is an actual physical problem, but the cause isn't medical. It's actually triggered psychologically. So you will see people who have some kind of psychological anxiety or stress, and they will actually cause themselves to become paralyzed or blind. So for all intents and purposes, they are blind. They cannot see. They need to be treated as a blind person. But there's no physical cause of that blindness. There's no physical cause of that paralysis. This is a somewhat unusual disorder, but it does happen enough, and it has been documented enough that the brain actually has that kind of power to cause paralysis, to cause blindness and other things, simply by some mechanism. They don't understand it, but it's usually some kind of anxiety or stress that triggers that. Impulse control disorders are on the rise. This isn't one we used to talk about, but apparently it's becoming more common. Inability to resist urges to perform acts or behaviors that are harmful to the self or others, and they're linking that to brain dysfunction. Things like gambling, or pulling your hair out, or the book talks about several examples of these types of disorders. So interesting, but not terribly common. Okay, our last group of disorders, in some ways the most interesting, the most difficult to understand the cause of, and the most difficult to treat. Even schizophrenia, if you find the right drug, it can be treated with medication. Personality disorders can't. So they're confusing and they're difficult. Dysfunctional personality traits that are stable and enduring across situations. They cause problems for people in social and occupational or work settings, and they're usually distressing behaviors to others. So this is kind of like saying the person's personality is sick, that their personality is so messed up that it's actually a disorder, it's actually an illness, and it causes them a lot of problems in dysfunction, especially is the big D for this one, because a lot of times they appear to be normal. They don't appear to be deviant. Many times they do, but many times they don't. And they often, many personality disorders will say they're not distressed, that it's the other person's problem. They're very good at making you feel like their dysfunctional behaviors are actually your fault, or that you're the dysfunctional one. So they don't often have the distress, and therefore because they're not deviant, they don't have distress, they don't self-report. Some of the disorders, like we'll see, are deviant, but this is often a situation with many of these personality disorders that there's no distress to the person. It's all the people around them that are the problem. But very dysfunctional. So you'll see how they have a hard time holding a job, they have a hard time functioning in society, they have a hard time maintaining relationships, and it's because these are kind of the people that are their own worst enemy, that make it very difficult for themselves because of their behavior. Again, as with all the other disorders, remember, this is an illness. Their personality is so dysfunctional that they are sick, and that's a very real thing. It's not something that a lot of times they are aware of or can control, and because of that, very difficult to treat. We're just going to look at two. There's several different kinds of personality disorders, but the two most common are antisocial personality disorder. This one, because of the name, people think, oh, they're antisocial. They just are hermits. They retreat. No, anti means against. They are against society. They have a disregard for the rights of others, for the rules and of law in our society. They don't have a conscience about what's right or wrong. So there's no remorse. They don't have any ability to empathize, and that leads them to do stupid stuff, steal cars, use people, manipulate people, kill people, in the most extreme. And there's this one you'll usually see starting in childhood with conduct disorder, and then it grows into the personality disorder. So these are usually males, not always, but usually. And they just don't seem to get the fact that what they're doing is hurting not only themselves but others. And then finally we have borderline personality disorder. Borderline kind of meaning where they're sort of on the border of, it refers to their sense of self, this unstable sense of self, where they can't quite get a handle on who they are. And because of that, it leads them to these really intense, manipulative, volatile relationships. They have this huge fear of abandonment, but you'll watch them do all sorts of things to push the other person that they don't want to leave them. They'll do all these things to push them away, to create this self-fulfilling prophecy. Their moods are very unstable. They can often be very impulsive, very self-destructive. So it's sort of the typical worst case scenario where they have all of these this instability in themselves, and that leads them to these behaviors that they get into trouble, and they self-destruct. But they're often also very smart and very good at manipulating situations, at manipulating people, at appearing to be one thing in one place and a totally different person in another place. So because they're very smart at manipulating situations and people, it's very difficult to help them, even though most of them desperately need help in order to be able to function. Okay, did you stick with me? If you stuck with me and you're still here with me, just email me the word abnormal. Just that word. Then I'll know that you stuck with me through the whole thing. I want to see how many people actually stuck with this long one. So email me at the word abnormal. That's it, and I'll know what you mean. To summarize, abnormal behavior exists on a spectrum. So again, we want to be very careful. This is just psychology. Again, psychology's way of defining abnormality so that they can help people, because there are people really distressed and suffering out there. But where do we draw the line? Where's the line on that spectrum where we go from normal to abnormal? Hard to know. The 3 Ds, I put 3 instead of 4, must be present for a diagnosis of abnormality, and that of course has a little asterisk because we know that sometimes people aren't distressed, sometimes they don't look deviant, and sometimes they can function, but they're still mentally ill. But we look for those 3 Ds to help us. The DSM is a great tool. Hopefully you'll have a chance to look at it at some point and kind of check it out, but it has a lot of limitations. And keeping in mind the biopsychosocial perspective can be applied to all these disorders, some of them better than others, some aspects better than others, but we want to make sure we look at the whole person, that we don't label. That's the other one that goes in here. That we be careful not to say, you know, this person is schizophrenic, they are an alcoholic. Alcoholism, by the way, is in the DSM as well. That we look at the person as a whole and we see them kind of as we see someone with cancer, that they are a person who is suffering from an illness, who's suffering from a disease, and they need help in whatever form that might take. So hopefully you'll remember these things as we go through this chapter, and you'll have a better understanding of mental illness, abnormality, and what that means for people in their own personal lives.